effort to eliminate the non-responders by using different imaging modalities. Regarding last guidelines, CRT is recommended for patients with ejection fraction less than 35% with QRS duration more than 150 millisecond or 130 in both left bundle and non-left bundle QRS morphology. What is the aim of multimodality imaging for CRT? Integrate current guidelines for patient selection, prediction of responders and non-responders, guiding optimal LV lead positioning. Our option for cardiovascular imaging: echo, CMR, multi-slice CT, and the nuclear cardiology. Patient selection. Regarding guidelines, ejection fraction is the only parameters that used for patient selection for CRT. But 2D echocardiography is the first imaging modality. However, three-dimensional imaging techniques have demonstrated their role in selecting heart failure patient for CRT. What about pitfalls of 2D echo? High intra-observer and inter-observer variability, up to 18%. About 20% of all patients would have been reclassified. Geometrical issue, apical foreshortening, and poor endocardial definition. So we need for other imaging modality for assessment of ejection fraction: 3D echo, CMR, and the nuclear imaging. The CMR is the gold standard for assessment of function and volumes. This trial study show the ejection fraction assessed by 2D overestimated. CMR would significantly increase the number of patients dedicated for CRT, about 28%. 2D ejection by this trial, 2D echo LV ejection fraction was significantly larger than CMR. For patients with lower ejection fraction and planned for device therapy or cardiac surgery, which should be applying the recommended cutoff value CMR measure rather than 2D echo. What about 3D echocardiography? 3D echo ejection fraction and volumes assessment has been reported to be accurate at the CMR. There is meta-analysis of 23 studies, including more than 1,000 transthoracic data set, confirmed that 3D echo is superior to 2D when compared with CMR. So recommend the ACC imaging and the American Society of Echocardiography recommend use of 3D for assessment of LV, especially for poor echo window. Finally, regarding guidelines for assessment of ejection fraction, CMR is recommended for assessment of myocardial structure and function in those with poor echocardiogram, and inpatient also in American guidelines, but also recommend the other imaging modality as CMR, CT, nuclear is recommended for assessment of ejection fraction. What about prediction of responders and non-responders? There is multi predictors for responders and non-responders as mechanical LV synchrony, RV volumes and RV systolic function, mitral regurgitation severity, scar, and ischemic and non-ischemic pairs. At the first, what about LV ventricular dyssynchrony? There are two types of dyssynchrony, electrical and mechanical dyssynchrony. Current guidelines include evaluation of electrical dyssynchrony, left bundle, right bundle, rather than mechanical dyssynchrony. But Multiple trials show no significant relation was demonstrated between baseline QRS duration and the improved in clinical and echocardiographic variables at 6 months follow-up. So we need other methodology for assessment of dysynchrony rather than electrical. This is LV mechanical dysynchrony, in which septal activation occur first, then delayed lateral wall contraction, which this reduce the LV pressure rise and make late activation of papillary muscle, causing mitral regurgitation. This is algorithm for pathogenesis of electrical and mechanical dysynchrony. If the patient, all patients with electrical dysynchrony have a mechanical dysynchrony, no. There is discordant between electrical and the mechanical dysynchrony. So assessment of intraventricular synchronicity is probably more important than QRS duration. How? There is a 2D tissue Doppler and the 2D speckle tracking, 3D speckle and CMR feature tracking. 2D speckle tracking. The gold standard for speckle tracking measured mechanical dysynchrony, opposing wall delay between radial stream peak of LV posterior wall and anterior septum. If more than 130, they indicate significant mechanical dysynchrony and improved ejection fraction after CRT. What about 3D? There are multiple modalities for assessment of speckle tracking by 3D. One of them triplane tissue synchronization imaging. This is tissue Doppler in 3D assessment of peak systolic time to peak S wave, 6 basal and 6 mid segment. Standard deviation of this time to peak indicate tissue synchronization imaging, which more than 33 predicted significant LV reverse remodeling after CRT implantation. Also, systolic dysynchrony index real time. This is no need for ECG gating 3D echo. This method divide the LV into 16 segment. Time to minimum systolic volume, which indicate maximum systolic contractility of this segment. Standard deviation of this time indicate mechanical dysynchrony. Value more than 6.4 predicted significant LV reverse remodeling after CRT implantation. This is figure show 3D real time. CMR feature tracking has a similar method for assessment of systolic strain using Cine CMR. CMR tissue synchronization standard deviation also of time to peak systolic velocity, providing estimate of LV dysynchrony. More than 110 milliseconds indicate significant dysynchrony and have higher risk for all-cause mortality and heart failure. What about RV volumes? Several studies show severely dilated RV volumes and impaired RV systolic function are poor responders for CRT and the predictor of high and worse prognosis. As RV function and systolic RV volume extensive indicate extensive and more severe cardiac disease beyond repair. What about mitral regurgitation severity? Significant secondary mitral regurgitation reflect worse prognosis and even worse deterioration of mitral regurgitation severity after CRT implantation, which could be improved after transcatheter edge-to-edge mitral valve repair. Scar extent and burden and ischemic versus non-ischemic. Multiple studies show scar volume, which increase of scar volume indicate poor responders to CRT. Also transmurality. whatever the segment affected. Transmural scar predict poor responders to CRT. Also ischemia. Ischemic heart disease prevalence significantly with non-responders. What assessment of a scar by CMR-led gradient enhancement and SPECT imaging. Optimal lead positioning. Optimal lead positioning is also important to maximize response to CRT. Patient with optimal site for implantation has significant reduction of volumes and ejection fraction improvement. Optimal lead positioning by assessment of latest mechanical activation segment by different methodology for assessment of speckle tracking, 2D, 3D, real-time, CMR, SPECT. Also transmural scar in posterolateral segment. What about coronary venous anatomy? This is done by cardiac multi-detector CT for assessment of coronary sinus for posterior vein of the left ventricle, which especially posterior interventricular vein and posterolateral vein. Course will presence or absence of target vein as this figure. This is angle and width. In this figure, 3D volume rendering, no small posterior cardiac veins, and this better posterior cardiac vein. Also, CT will inform us about any anomaly. This is persistent left superior vena cava. Also, this communicating fistula between coronary sinus and right ventricle, right coronary. This is Rogier syndrome, absent coronary sinus with persistent left superior vena cava drained into left atrium, and inferior vena cava, right superior vena cava and drained into right atrium with no coronary sinus. Take home message. Main question should be answered pre-CRT. What about ejection fraction? Better CMR and 3D echo. Presence or absence of mechanical dysynchrony either by 2D, 3D speckle, real-time 3D echo, CMR feature tracking, RV volume and function better by CMR, mitral regurgitation severity better by echo and CMR, scar transmural and scar burden by CMR or SPECT, ischemic heart or not, CMR, SPECT, coronary CT, anticipate left lead positioning either by posterolateral scar, latest mechanical activation, likelihood of responders to CRT. If no low likelihood for respond to CRT, no significant LV synchrony, extensive scar, or present of transmural scar at the posterolateral segment, coronary venous anatomy not suitable for LV deployment, and the site of lateral activation. High likelihood for responders, significant LV synchrony, no significant amount or less than 50% of transmurality, and the location away from posterolateral segments. Coronary venous anatomy permitting optimal LV lead positioning as a site of latest mechanical activation. This is algorithm for assessment of patient for CRT, patient selection, pre-patient implantation, and post-CRT implantation. Thank you.
Good evening, everyone. First, I would like to thank the organizing committee for inviting me to attend the CardioEgypt Congress and to talk about this important topic, which is left bundle pacing versus biventricular pacing. I just make a little modification in the title. I mentioned left bundle pacing area, left bundle branch area pacing versus biventricular pacing, and I will mention at the end of this presentation why I mentioned that. Yes, first of all, I would like to mention what is dysynchrony. As mentioned by Dr. Mohammed Baha, it is an impaired mechanical coordination between the cardiac chambers due to impaired electrical activation of the heart. And usually electrical dysynchrony identified by the white QRS complex on ECG. And this typically occurs due to associated conductive disease like bundle branch block. One of these causes is a left bundle branch block, which causes intraventricular dysynchrony between the delayed contraction between the septum and the lateral wall of the left ventricle, which causes a reduce in the stroke volume and cardiac output. Unfortunately, about 1/3 of patients with heart failure and reduced ejection fraction have a wide QRS complex. And this dysynchrony in those patients can further lead to reduction cardiac output, worsening functional mitral regurg, adverse left ventricular remodeling, and increased mortality. And up till now, the cardiac resynchronization therapy, which is the biventricular pacing, is an effective therapy for patients with half-RAF and associated with electrical dysynchrony, which, according to many clinical trials and randomized large trials, shows considerable improvement in the quality of life, reverse myocardial remodeling, even some improvement in the ejection fraction, and decreased in the morbidity and comorbidity in this patient with electrical dysynchrony. And according to the most recent guidelines on cardiac pacing and synchronization in 2021, and even the previous guidelines on heart failure in 2020, CRT is the class 1 indication in any patient with half-RAF associated with ejection fraction less than 35% and has a wide QRS complex left bundle more than 150 per millisecond as a class 1 indication, or from 120 or 130 to 149 as a class 2A indication. Even in patients with non-left bundle morphology of QRS complex, if it is associated with wide QRS complex more than 150, is a class 2A indication to implant CRT. But at the same time, in most studies, still 1/3 of these patients non-responder due to multiple factors like imperfect selection. As mentioned by Dr. Muhammad Baha, electrical dysynchrony may not reflect the mechanical dysynchrony. Unfortunately, there is a subset of patients, not the wide QRS complex is only a predictor for this dysynchrony. Also, presence of multiple or large areas of non-viable myocardium and associated severe RV dysfunction and elevated pulmonary hypertension, which maybe become worse by the RV pacing. Also, failure to implant CRT. No optimal veins or tributaries to be implanted, and you sometimes implant the lead in a suboptimal position like anterior cardiac vein, middle cardiac vein. Inadequate programming, AV delay, for example, VV delay. And sometimes the arrhythmia itself can interact with the CRT, like atrial fibrillation, frequent BPCs. So the scientists try to find another solution to solve some of these conflicts or these problems with CRT. And during this research, there is an innovation of conductive system pacing. CS pacing means direct activation of the conductive system of the heart by pacing stimulus to mimic the physiologic activation of the heart, electrical activation of the heart. Many trials studied the proximal hip bundle pacing, distal hip pacing, right bundle branch pacing, left bundle branch pacing, left septal ventricular pacing, even left fascicular pacing. And today I will talk about the left bundle branch area pacing. That's why I mentioned area pacing. It means that I capture subendocardial area on the left side of the intraventricular septum, with or without simultaneous conduction system capture, and includes both either selective left bundle branch or left fascicular pacing or left ventricular septal pacing. And there is many studies the conductive system pacing versus the conventional 2D DDD or dual chamber pacing like Sharmas et al. And they compared between the left bundle area pacing and RV pacing, and we found that left bundle area pacing associated with narrower QRS complex mimics the physiologic pacing, and even in the primary endpoints, it causes decrease in the mortality in these patients who are dependent on pacemaker, and it decreases the incidence of pacing-induced cardiomyopathy and heart failure hospitalization, and even the need for upgrade to CRT. That's why becomes the conductive system pacing in the last guidelines published by Heart Rhythm Society. If your patient is indicated for a reason of bradyarrhythmia and you suspect that he has a substantial ventricular pacing more than 20 to 40% of total time, you may implant TDD. But if he has a mid-range impaired ejection fraction from 36 to 50, which is not in strict indication for CRT, you can implant either CRT or conductive system pacing as a class 2A head-to-head together to decrease the incidence of risk of pacing-induced cardiomyopathy. But if this patient has a normal ejection fraction, it's still to be either biventricular pacing or left bundle area pacing. But what about the patient who has a half RAF with wide bundle electrical desynchrony and there is no need for bradycardia, there is no bradycardia indication? Is CSP pacing effective for achieving synchronization as CRT? They started by his bundle pacing, which is a more physiologic site of pacing. And this randomized trial by Vinther shows that his bundle pacing implanted in patients which has the same indication of CRT as a class 1 or class 2A indication in patients with half RAF and left bundle branch block. The left bundle area pacing is associated with narrower QRS complex than the CRT. But as regards the quality of life, NIHA class, echo parameters, and 6-minute walk test, by 6 months, there was no difference between the CRT and left bundle area pacing. His pacing. But the problem of the his pacing, and still is a considerable problem, is the high threshold. The problem in the his bundle pacing that to capture the myocardium, you need a higher threshold than the CRT itself and the left bundle pacing area. That's why they started to study the left bundle pacing area pacing. Why? Because it needs lower threshold, even more than the CRT, with good stability of the leads and good sensing. And according to Vigerman et al., which included 16 international centers, left bundle area pacing was attempted in patients with straight indication for CRT, but failed to implant the CRT due to lead complications, or in some patients with non-responding to CRT. And they follow this patient with left bundle area pacing, and they found that there is improvement in the QRS duration, improvement in the NIHA class, and even ejection fraction and echo parameters improved in this group of patients. And they compare between the patient who implanted the left bundle area pacing in patient who has a failed CRT implantation versus the non-responder. Yes, the effect of left bundle area pacing is good, improved, but when we compare the both, on the long run, the non-responders which was inferior to the patient who implanted the left bundle area pacing due to CRT technical problems in implantation, which reflects that the non-responding to CRT, it is not only due to CRT device itself, but also due to other extra factors regarding the patient itself, like mitral regurg, pulmonary hypertension, and so on. If there is any trials who compared directly between the left bundle area pacing and CRT head-to-head to see if there is any difference between them? Yes, this paper published this year, and they compared between left bundle area pacing versus as a group and versus patients with BIV pacing, and they found that. And they also assessed 3 points: the electrical synchrony, the mechanical desynchrony, and the hemodynamic during the cath lab during implantation of these devices to see the pressure in the left ventricle improved or not. And they found that, yes, the left bundle area pacing causing more narrowing QRS complex, but as regards the mechanical desynchrony, there is no significant, both improving the mechanical desynchrony, but there is no difference between both groups, and even, but during acute response after implantation, the left bundle area pacing was superior or more in improving of the pressures inside the left ventricle than the CRT. And they said that left bundle area pacing, it is a solution or can be comparable to the CRT. Also, this paper, which was published also in last January, they compared between left bundle branch pacing, selective pacing, versus the ventricular septal pacing in patients who has an half-RAF and indication for CRT. If there is a difference, you should implant your device, your lead inside the left bundle to get a better response. According to this study, they divided the patient into three groups. Group with left bundle branch pacing, either selective or non-selective, patient with left septal pacing, ventricular left septal pacing, or patient who has a deep septal pacing, not right, not left, mid-septal. And they found that the worst prognosis was in the patient with deep septal pacing, while there is no difference between the left bundle branch pacing and left ventricular septal pacing as regard improvement in ejection fraction, CRT response, and the echocardiographic parameters. What about if I combine the CRT with the left bundle area pacing? This is the LOT CRT device, just 2 slides. They used a special battery, DF1 actually, to allow to put the lead inside the left bundle pacing area pacing and LV lead inside the coronary sinus, and they found that it is causing more and more narrow QRS duration and more significant improvement in elective ventricular ejection fraction and NIHA class and echocardiographic parameters. But still, there is no head-to-head of this protocol or this technique regarding the left bundle area pacing alone. It is just at one-arm trial. So according to the guidelines of HRS, as regarding patients with indication for CRT, still the CRT is a class 1 indication in left bundle branch block in half-RAF patients if more than 150, and class 2A if from 130 to 149, and his bundle conductive system pacing, either his bundle or left bundle area pacing, it is a class 2A. Especially in patient who has a difficulty in implantation of CRT or non-responder to CRT, but still there is a limited role of conductive system pacing in the non-left bundle branch because of limited studies on this topic, especially just they tried it on his bundle pacing, not on left bundle area pacing. My take-home message: electrical dyssynchrony is a significant contributor for reduction of quality of life and increasing mortality and morbidity in patients with heart failure. Still up to now, the CRT is the sole effective therapy in this type of this patient, and we can consider that left bundle area pacing may provide additional modality for cardiac synchronization therapy in addition CRT, but still its role on patients with non-left bundle branch morphology not clear and not well studied. Thank you.
شكرا جزيلا, very clear وبين. CRT, ICD or CRT pacemaker. So to come back to the very first step, what are the benefits of the CRTD? It's quite clear: terminate ventricular arrhythmias, get a lower rate of arrhythmic deaths, and the last one is really personal. If there will be no need for an upgrade from CRTP to CRTD, but I really hate to put an ICD leader CRT pacemaker patient. What are the costs? There are some medical costs, possible inadequate ICD therapy. I don't know anything about higher rate of infection. I did not find data on higher rate of surgical reintervention that could be a cost, because ICD leads are more prone to problems, and device longevity is for sure shorter for ICDs. And of course, the next question for a clinic: how to optimize resources, and similarly the question for the health fund: how the more expensive CRTD is available for our population, or is it enough to implant a CRT pacemaker for these patients? So if we look to the heart failure guidelines, there are practically 3 different patient populations. There is the patient population where there is clearly no need for device. There is a patient population where there is a need for a primary prophylactic ICD. I cut out the patient, of course, where there is a clear need for ICD because of ventricular tachycardia or survived sudden cardiac death. And there is the third patient group where there is a clear indication or more or less clear indication for CRT, and there is practically everywhere D or P mentioned in all the guidelines. Let's look a little bit on the CRT side, on the ICD side. The question, what comes next to answer is why do the patient die? What are the different cause-specific mortalities? That can be cardiac arrhythmic, can be cardiac non-arrhythmic, practically heart failure mortality, or non-cardiac or non-cardiovascular mortality. The further problem with the ICD is that it cannot save all patients from cardiac arrhythmic death. So that was an early study more than 15 years ago. There still approximately 16% of the ICD patients die of cardiac arrhythmic causes. So we diminish the cause of death, but cannot save all patients for eternity. There is a nice MADIT ICD score for primary prevention that was published 2 years ago, where they got all the MADIT studies and tried to calculate which is the main cause of death. And there on the left column, you see where there is the lowest benefit of an ICD when the mortality for non-arrhythmic mortality score is high, the risk for arrhythmic mortality is low, there is not a big benefit of ICD. If the VT-VF score or VT-VF risk is high and the non-arrhythmic mortality is low, like here, then the patient would benefit really much from the ICD therapy. The score needs a little bit calculation. So there is on the left side, we can calculate the VT and VF. On the right side, the non-arrhythmic mortality score. Difficult will be the question when these patients are in the middle range with low VT score and low non-arrhythmic mortality score, or high on both sides, because then we have practically parallelly higher or lower risk for mortality. There is one minus point that you can connect, that you can see here, is the CRTD. That means, of course, if you implant a CRTD and the patient is responded, then the non-arrhythmic mortality will be hopefully lower. Last year, we have finished a study that was initiated in Hungary, the Budapest CRT upgrade. Some of you are knowing this. That shows that in patients with a high rate of ventricular pacing who have an ICD and pacing-induced cardiomyopathy, the upgrade to CRTD has a huge benefit, which is not a big surprise, but we could prove it really nicely in a randomized study. So adding a CRTD to ICD in these patients is an important option. If we go back to the guideline, patient with an indication of CRT, you should decide CRTP or CRTD. One axis is myocardial fibrosis, the other axis is age, and there are a couple of points that could have a factor favoring CRTP rather than CRTD. There is a meta-analysis that have been published this year by the Semmelweis group on mortality on CRTD versus CRTP, but you see practically in both figures that CRTD may be better or may be the same practically, depending on the study that was studied. Altogether, if you are looking at all-cause mortality, the CRTD is better. So the relative mortality reduction is 26%, which is pretty nice. On the other hand, there are patient populations where we don't see this benefit of CRTD. These are the non-ischemic patients, and these are the elderly patients in this huge study involving 130,000 patients. You may remember on the Goldenberry score in ICD, there's similar calculations were done again by the Semmelweis group. And the long-term mortality reduction shows quite nice. The patients with terminal renal failure were excluded. They are the very high risk patient population, but this J shape is quite similar to the Goldenberry score in the ICD therapy. So patients with low risk factors have a bigger benefit than patients with high general risk factor. Which are these risk factors? Atrial fibrillation, higher Ginha class, higher age, renal failure, and the wide QRS. And here you see the mortality rate, which can be seen that the CRTD has a lower mortality in the low risk group, and in a high risk group, the mortality difference between CRT pacemaker and CRTD is getting smaller. And this is the last topic, which is really interesting. There are 2,500 patients, or close to 2,500 patients involved. That is retrospective single-center analysis of CRT pacemaker and CRTD, the recipients. And you see there is some difference that CRTD patients get some better survival than CRTP patients in both in ischemic and both in non-ischemic patients. Not a huge difference, but 15 to 20% difference, which is nice and significant. So this funny picture was made by the artificial intelligence, which tried to find similar patients based on 25 clinical parameters. So the similar patients were collected together, and dissimilar were put away and far away from each other. And there were 5 phenogroups that could be found. The one are these in these red brackets are the phenogroups with high risk of mortality. These are the patients with ischemic etiology, where the patients have similar. These are the ischemic etiology patient with high risk of mortality. On the left, the 2 green groups are the patients with lower risk of mortality, mostly with non-ischemic etiology. But if we see it, if we look the survival difference with CRTD and CRT pacemaker, we can see that in both groups there are patients where there is a difference between CRTD and CRT pace survival, so better effect of CRTD, and there are patient populations both on the high risk and both on the low risk group when there is no big difference between CRTD and CRT pacemaker. So these are the survival groups of survival curves of these 5 phenogroups. You see the left 3, so 1, 3, and 4, the overlapping curves, and you see the phenogroup 2 and phenogroup 4, one in the low risk group, one in the high risk group, where there is a clear benefit of the CRT ICD compared to the CRT pacemaker. So to conclude, the 2 main message, or the 3, CRTD versus CRTP remains still an individual decision, looking at the patient. If we are looking at the meta-analysis, patient with CRTD had a 26% lower mortality risk than CRT pacemaker patients. There is never a mortality benefit on the CRT pacemaker side, but there is a lack of additional mortality benefit with CRTD in non-ischemic patients and elderly patients. And the other major message is that it seems to be possible to identify patient subgroups where CRTD patients have better survival and a similar survival, and where in patient groups where the survival is similar in CRTPs and CRTD patient population. Of course, we would need a nice CRTD benefit score that I could not found by it, but we can develop one. Thank you very much.
Thank you very much. Very clear. To summarize the criteria for selecting CRT defibrillator, if the patient was having scar, ischemic coronary disease with scar, or resuscitated sudden death or recurrent VTAC. So these are clear indications.
These are completely clear indications, right. So scar, if we cannot really decide, we try to get some MRI, and if there are scar tissues in the myocardium, then we mostly opt for CRTD because of possibility for VTs and ventricular tachyarrhythmias.
Thank you.
Thank you.
If there is no question, thank you.
Thank you.
Next speaker, Ahmed Dalal, spirovena cava, the unpleasant surprise.
السلام عليكم. أنا هقلب كده. First, thanks for Iris for this invitation, and this is a great honor for me to stand in front of you. Inshallah. CRT therapy. The insertion of what is the CRT or cardiac resynchronization therapy? It is the insertion of electrodes in the left and right ventricles, as well as on occasion on the right atrium, to treat heart failure patient by coordinating the function of both right and left ventricles via a pacemaker. This is the normal venous system of the upper limb. Let's start by the junction between brachial vein and cephalic vein. They will give the axillary vein, which is at the lower border of the teres major muscle. Axillary vein will receive the cephalic vein and continue until the lateral border of the first rib will it passes under the clavicle, which will continue as a subclavian vein. Subclavian vein will receive the external and internal jugular veins, then continue as a brachiocephalic vein. This is on both sides. Brachiocephalic vein right and left unite normally to give the superior vena cava, which drains into the right atrium. This is the explanation of what I said. This is the usual picture of the normal CRT. CRT in the left prepectoral area. The 3 cables arising from this battery. One go to the right atrial appendage, one go to the RV apex or RV apical septum, and the other going to the LV lateral wall, basal and mid lateral wall. This is the fluoroscopic presentation of what I said. Battery, 3 leads, the first arrow for the RE lead, the dashed arrow for the RV lead, and the red arrow for the LV lead. Let's come to our topic, persistent left superior vena cava. What is the persistent left superior vena cava? Its incidence is seen in 0.3 to 2% of the general population. Prevalence much higher for patients with congenital cardiac anomalies. What is Schomer's classification? It is the classification of the right and the left superior vena cava. Type 1, it is the normal variant that is present on all of the population. Only one SVC running on the right side. Type 2, it is isolated persistent left superior vena cava. Type 3, presence of both right and left, and there is communicating left brachiocephalic vein in between. Type 3B, right and left without communication in between. Let's come to the embryological background. How persistent left superior vena cava develop? Usually we have what is called cardinal veins. Anterior cardinal veins, posterior cardinal veins, all of them are present right and left. في anterior cardinal veins على right, في anterior cardinal veins على left. Portion of the right anterior cardinal veins. طبعا أولا الانterior cardinal veins مع posterior cardinal veins unite to form the common cardinal vein. Also there is one on the right, one on the left. Portion of the right anterior cardinal vein and the right common cardinal vein develop into the SVC, right SVC. Part of the left anterior cardinal vein regresses, leaving the ligament of Marshall, which ends in the coronary sinus. Rarely, the left anterior cardinal veins fail to regress and form what is called persistent left superior vena cava, which usually drains in the right atrium via the CS, but in rare cases can drain separately without junction to the CS. Unless associated with other significant congenital anomalies, it is usually asymptomatic or often discovered incidentally, and so no need for any surgical or medical treatment. How can we suspect the presence of persistent left superior vena cava? First, from echo, we will find accidentally dilated coronary sinus. Usually it is less than 1 centimeter diameter, but if we found more than 1 centimeter, we should suspect and confirm in the apical 4. We will find this. Just gentle manipulation of the probe, we will find very big CS draining into the RA. More confirmation by the bubble study, agitated saline. This is a very good point. First, we should do the agitated saline from the left arm, not from the right arm. From the left arm, we will find opacification of the CS before opacification of the right atrium and the RV. In the apical 4 will be more obvious. I will find opacification of the CS and I will find the agitated saline flowing from the CS to the right atrium. This is a confirmation. More confirmation by the CT angio طبعا. Type. Detection during implantation. Detected incidentally when a left cephalic, axillary or subclavian approaches are used. داخل من على الليفت لقيت الواير بتاعي ماشي على الليفت border of the heart مش على الرايت border of the heart. During advancement of the guide wire, unusual route was observed that bypassed the left lateral border of the cardiac silhouette to the anterior to the inferior vena cava. This can be confirmed by venography. Yes, to stop and make venography before advancement of the belloway. We will find this is the wire. If we do venography, we will find this image. Persistent left superior vena cava without communicating vein. This is the type 2, that's what I said. Left subclavian, right subclavian, both of them unite into one SVC, which is the left SVC. No any right SVC here. Type. Let's come to the next type. Both we have left subclavian, right subclavian, small communicating brachiocephalic vein in between. What will we do now with this challenge? If we see this image, it will explain most of the challenges that we face and how we solve them. First, let's start with the right atrial lead. If we see the right atrial lead flowing from the persistent left superior vena cava to the CS, first there is a right angle here. It will be difficult to advance the belloway, to manipulate of the lead. This is all of the lead, not only the RA lead. The second challenge, after the lead going to the right atrium, it will go directly to the lateral wall. Lateral wall, it is not a recommended area because of 3 risks. Less stable perforation and sometimes phrenic stimulation. That's why we want to solve this problem. How? Just by broad curve of the stylet with gentle angulation of its tip so as to I can catch the lateral border of the right atrial appendage here, away from the pure lateral wall. Some papers said what about the VDD, that I can put RV lead with 2 sensing bipoles here to compensate for and overcome the RA lead at all. But many papers after that said this is not practical because the VDD already not used now. More over sensing. انا في السي ار تي اهم حاجه عندي الاتريال سينسنج عشان اعمل التراكنج بالباي بي بعد كده. More atrial over sensing and less stable bipole with the cardiac output. Let's come to the RV lead. RV lead is the same. It will go through the persistent left superior vena cava to the coronary sinus. It will go directly also to the lateral wall, but I need accurately the opposite direction at all. I want to go to the septum here. How? That's why I need a specific manipulation and a specific curve of the stylet, which is called alpha curve or cursive L curve, شكل حرف L المتصلة. هنشوفه دلوقتي إن شاء الله. To go to the RV apococeptum. Let's come to our challenge, the LV lead, because the time, no time now, I will speak rapidly. LV lead. There is a rule. If you find persistent left superior vena cava, you should do right venography to see if there is a right superior vena cava to compensate for that or not. This is what is called hybrid technique. احط الار في والار اي من هنا واحط ال في من الناحيه الثانيه. طب ليه هحاول احطه من الناحيه الثانيه؟ لان لما باجي ادخل من هنا انا عندي كورونري ساين. عشان اقدر اعمل اوكليوسيف فينوجرافي هجيب بالونه قد ايه عشان اقفل الحته ديت عشان خاطر اشوف الفينز اللي هنا. النقطه الثانيه ان هجيب صبغه قد ايه؟ ده انا محتاج انجكتور، السرنجات العاديه مش هتعمل حاجه في الحاجات دي. فالهيوجلي دايليتد رايت كورونال ساينس دي after the junction with the persistent low zone again بنحاول بالبالونه above the junction above the fusing valve. لكن بعد الفيوزنز فالف انا قدامي سكتين، يا اما ربنا يكرمني باي بوسترولاترال او انترولاترال فين هين، يا اما فين ادور على اللاترال برانشز بتاعته عشان احاول. بس في بروبلم كبيره هنا، انا عندي الليد داخل كله ماشي كده، انا عاوز امشي ان ذا اوبوزيت دايركشن. مين انا عاوز امشي انجل مور ذان 180. ازاي هقدر اقلب السب سيلكتور بتاعي كده، الجايد تشيس بتاعي كده، الوايرز كده؟ That's why I need special equipment, special sub selectors, special shaping of the stylet and special wire technique as body wire technique as we will see. يبقى there is a problem here if I went to the left side. Let's try if I find the right side. The right side I can do overcome all these problems. But side not preferred for many causes. Sometimes I cannot find the processor, the right superior vena cava at all. Sometimes I need CRTD or ICD. The left side is preferred for the shock vena. Sometimes the ostium of the CS is very distorted. How can I solve? Distorted, elongated, slit shaped. How can I go? That's why I need special catheters. Need ambulance catheters. Special long sheaths with special curves so as to I can navigate the ostium here. Sometimes بندخل بقسطره عشريه steerable catheter من فوق او من تحت، اعملها كاريلا واي عشان اعرف ادخل عليها. طيب sometimes if steno of the CS this is called a snare. بدخل ببي تي سي اي واير 014 من هنا، ادخل من الفيمورال من الفيمورال سنيرنج للواير بحيث اني اشد الاوستم شويه، اعملها كاريلا واي للسي اس ليد عشان يدخل من الرايت سايد. اوكي خلاص على طول ان شاء الله. This is also في ال في ليد عشان انا بمشي هنا زاويه 180. دلوقتي البيبرز الجديده تقول لك better to put an active في ليد، دي احنا ما شفناهوش كتير، احنا كل شغلنا بس في فيكسيشن وذ سبيشال كيرفز. ميترونيك مصنعه الليد دوت. This is an active fixation LV lead for more stability of the LV lead. لان الموست common problem after insertion the LV lead في with persistent left vena cava is the dislodgement. انا ما عنديش سلاك، انا ما عنديش اي حاجه اريح الليد عليها. This is the cursive L lead. This is the broad curve lead with a special angulation here too. This is for RA lead. This is the explanation of what I said. This is a fluoroscopy for RA lead and the RV lead. This is the barrel wire technique as I said. I found a vein here. After that في سب سيلكتور دخل فيه اهوت، بعد كده حطيت وايرين عشان يديني سبورت اكتر، بعد كده دخلت بالال في ليد معايا. ده ابروش بس من الرايت سايد، دخلت لقيت انترولاترال فين معايا هنا عشان اجيب الشيلونج شيس مش هيعرف، دخلت بسب سيلكتور لعند ما وصلت له حقنت وركبت ال في ليد. ان السوبيريور او upper limb anomalies such as persistent left superior vena cava can make cardiac device implantation technically challenging, but with increasing operator experience, with more advancement in cardiac imaging and appropriate tool, device implantation is possible in almost all cases. Thank you.
شكرا جزيلا. كان في حالة الدكتور محمد